Hi everybody. This PowerPoint is going to be presented in a Pecha Kucha format. What that means is that we're going to have 20 slides for 20 seconds each. Today's presentation is going to be on a basic respiratory assessment. Let's start with reviewing just a little bit of basic anatomy. As you may recall, the lungs are made up of a series of 5 lobes. The right side has an upper, a mid, and a lower lobe, while the left just has an upper and lower lobes. If you can't remember which side is which, just try and think of the left side making room for the heart. The network of pathways inside the lung fields all come to an end point where the structure of alveoli are found. These are like little collapsible air sacs. These help with the gas exchange while we're breathing. How that works is the blood comes past the alveoli and exchanges deoxygenated carbon dioxide into the alveoli for oxygen. The deoxygenated blood receives the blood from our respirations and gets passed along. In order to make sure that our patients are receiving proper oxygenation saturation, we need to do full respiratory assessments. Of course, all assessments start with a good history review. Make sure you don't forget to review that chart. When you first walk into your patient's room, you will need to do a quick priority assessment. This means laying your eyes on everything and making sure you understand where your priorities are going to be. How is your patient posturing? Are they sitting in a tripod posture? Do they look like they're breathing all right, or do they look like they might be struggling? What does their skin look like? Cyanosis is when you see a blue tinge to the skin, and it is a sign that oxygen is not perfusing the tissues adequately. These photos show cyanosis of the lips and on the fingertips. You might also notice cyanosis or mottling on the feet. Also take note of if your patient is coughing. If they are coughing, is it productive? And if it is productive, we need to look at that sputum too. Because when it comes right down to it, clear or creamy white sputum is going to mean something different than a heavy, thick, frothy sputum kind of infection. Don't forget to check the capillary refill as well. That's done by squeezing the nail bed and then looking at the rate that that bed becomes pink again. Do you remember what the normal cap refill rate is? Also, we need to take the saturation reading. Don't forget that people with chronic obstructive pulmonary disorder will normally have lower readings than someone without this disorder. When we're getting ready to do auscultation and listen, the ideal situation is having your patient sitting upright. The first order of business will be a visual inspection. Take a look at the chest. Make sure you're taking notice of any lack of symmetry. Do the rib cages look like they're lined up? What about the back? Don't forget that as well. When we're visualizing, we also need to take note of any abnormalities. Does your patient look like they might be barrel-chested? Or is there funneling evident? Also, take note if you're able to see any visible masses. All of these indicate things that might need to be investigated further. We're also going to check for what we call chest excursion. That's making sure that that rib cage is expanding and contracting appropriately. Place your thumbs at the sternum below the breastbone with your fingers flared out along the sides of the patient. Ask them to take a deep breath. We'll be doing this on the back as well. Making sure that you're checking excursion means that you're seeing that your thumbs are spreading apart when your patient takes that deep breath. As you can see in the picture, the thumbs are further apart in the bottom picture than they are in the top. This indicates proper excursion. When we're auscultating, we are going to be starting by placing our stethoscope in the bronchial area and then going across. We'll then go down and across again, down and across. This side-to-side motion ensures that we're checking the symmetry and comparing the right side to the left. We will repeat this on the back, going across, down, down, etc. Make sure that you also get around to the sides when you get to those bases. We need to ensure that we're checking all the lung lobes and all of the fields. Let's see what normal lung sounds sound like. Bronchial sounds, or sounds heard up towards the throat, are going to sound like this. Whereas vesicular sounds are going to have a bit of a different sound and be more like this. Crackles, or rales, indicate that air is passing over an area in the lung fields where there is some consolidation of liquid. These are usually brief and not continuous. Wheezing is heard when air passes through an area where the passages are narrowed. You'll usually only hear this on expiration. This is more common in patients with asthma. When the air passes over an area where there's mucus secretions, we're going to hear something called rhonchi. As you can tell, that sounds pretty similar to wheezing, but you could ask them to cough and see if it clears. Whatever you hear, you need to make sure that you document it appropriately. If you're unsure, it's okay to double check or have someone else take a listen, but always make sure that you're thorough and you're using your best judgment when you're documenting. We need to keep things subjective in order to be able to put proper nursing care plans in place. While these aren't all of the long sounds that you'll hear, I hope this gives you a basic understanding of some of the things that you might come across. Good respiratory assessments are important in making sure that our patients are in the best health possible. Make sure you practice, and I'll see you in the lab.